Great. Well, fantastic. Again, thank you so much for having me. And it is a real pleasure to speak to this audience. And thank you to Stargards Connected for organizing this webinar. And thank you for Belite Bio and Nina for being here as well. Um, just okay. So yeah, so I'm a specialist in inherited retinal degenerations. I'm here at the Duke Eye Center in North Carolina in the United States, where we are one of the clinical sites for the Belite Bio clinical trial for Tinlarebant, as it's being evaluated as a potential treatment for Stargardt. And before I get into all of that, I just wanted to say that this is a particularly exciting time in the Stargardt field. This is nothing like it was even 5 years ago, let alone 20 years ago. There are so many things going on right now, and we're talking about Tinlarebant today, but in addition to that, all of these other potential therapeutics that are being evaluated in clinical trials right now, like the gilteritinol that's also in trials, also a very promising medication. There are more invasive therapies. Nothing wrong with being more invasive if it's efficacious. So there are gene therapies like the one by Splice Bio, very innovative technology. Um, Other type of genetic material editing approaches, like the one by Ascidian, for example. And I also wanted to mention, as I frequently tell my patients who have more advanced stages of disease, um, and for whom something like gene therapy wouldn't necessarily be particularly helpful. Uh, uh, I just want to say that doesn't mean that that's game over for vision in that eye. That's not the end of the story for that eye, because now there are these vision restorative approaches that are being evaluated. People have heard of stem cells and artificial retina implants, but in particular, I think what makes me excited is the possibility of this optogenetics approach. So a lot of exciting developments happening now, and I think in the field we're all kind of um, you know cautiously optimistic that something will come through. But let me, of course, focus on Tinlarebant for now. And before I get into the details, I wanted to step back and because people in the audience might have different levels of understanding and familiarity with how Stargardt works. So I wanted to take a step back and just cover the basics of it. So, why does Stargardt disease exist? So typically, what happens is we've all heard that, vitamin A is great for your vision. Eat your carrots, to have good vision. And under normal circumstances, it is good for your vision because vitamin A is, the basically the source of this family of compounds called retinoids, which is just modifications of vitamin A. And retinoids are used by the retina to run what's called the visual cycle, basically to facilitate the process of vision. So retinoids are important for vision, and normally everything goes smoothly. There is one key actor there in the visual cycle called ABCA4, and I'm sure that all of you have heard of that gene. Um, that gene makes sure that these retinoid compounds are handled properly. And if you don't have that gene, the functional, ABCA4, uh, some of the retinoids uh, basically turn into a toxic version of themselves. And they don't get cleared from the retina. They just sit there for as long as they last, and they slowly do damage to the retina, and that is the basis for Stargardt. So, as you know, anyone who has been diagnosed with Stargardt has surely been told, stay away from vitamin A, stay away from, multivitamins, any supplements that might contain vitamin A or beta carotene, which is basically this, it's almost the same thing as vitamin A. Um, and that's all correct. Uh, However, the and the basis for that is you reduce the amount of vitamin A that's coming into the retina. You consequently reduce the amount of toxic byproducts that are built up in the absence of ABCA4. Um, However, it's not so easy as it turns out to trick our bodies because they've had, millions and millions of years of evolution to get us here. So um, the retina is designed to get what it needs to have to facilitate vision. So you might be reducing the amount of vitamin A that you're exposed to, but the retina is going to be working hard to make sure to get that vitamin A even when you don't have a whole lot in your system. So for that reason, we need a better approach to prevent vitamin A influx into the retina. And so this is where tinlarebant comes in, and this is why in my opinion, such an exciting development scientifically and hopefully medically. Uh, what tinlarebant does is it um, interferes with the process of bringing vitamin A from the bloodstream into the retina. And it does so by interacting with a specific protein in the blood called RBP4, and that stands for retinol binding protein 4. So basically, it's a protein that takes vitamin A derivatives from the liver and the blood and moves them into the retina. And tinlarebant comes in and blocks that from happening, or at least significantly reduces it. And now you have a more selective, kind of specific way to interfere with this process, as opposed to just limiting your vitamin A intake. Um, you have a retina targeted way to interfere with this. So that's the basics of what we're talking about here with tinlarebant. And um, uh, hopefully that makes sense. This for those participants who are a little bit more detail oriented and want to get into the nitty-gritty details. Here's a little bit of what we call pharmacokinetics and pharmacodynamics data. So what I'm showing here is a graph where um, this in blue we're looking at a curve of a graph of patients who are taking tinlarebant, and we're sampling the level of tinlarebant in their bloodstream. And so we see, as expected, when somebody starts taking tinlarebant, their level of that drug in the blood goes up, and it stays up until they are off of the study. So as expected. And what is striking to see is that when we look then at the other curve in red, that is the level of this RBP4 protein that transports retinoids. And we see that there is a concomitant, very significant reduction in RBP4 in these patients that coincides with the exact time when tinlarebant is present in the system. So, uh, so this basically confirms that, first of all, tinlarebant gets into the system very well and is available to the body. And secondly, that it does what it is intended to do. It blocks this transporter protein. Um, and it blocks it down to below 80% of its initial value. So rather significant. Uh, of note, there was no rebound. There's a phenomenon called rebound that we sometimes see with medications in general. If you treat with a medication, then you withdraw the medication, uh, the original condition might go not just return to its baseline, but go even higher. We don't see that here at all. Uh, so this is very promising. So now let me get a little bit into these clinical studies. There are two clinical trials with tinlarebant, both called Dragon. First one is Dragon, and the second one is Dragon 2. Makes sense. Um, and they're quite similar. I'll go over the details here. So in the Dragon, one key difference is that Dragon is already fully enrolled and expected to be completed at the end of 2025. So for potential people interested in participating in some of this research, um, Dragon 2 would be the trial that is still open and enrolling, and um, certainly we're welcoming any interested potential participants. So both trials are global, multiple sites across different countries. In Dragon 2, for example, there are sites in Japan, UK, and the US. Uh, in Dragon 1, the randomization was there were for every two patients on the Tinlarebant drug, there was one patient on the placebo, which is just a sugar pill essentially. Um, in Dragon 2, this is a one-to-one ratio. So if you enroll into Dragon 2, you won't know, and the physician won't know what you're actually getting, and there's a 50% chance that you'll get the drug and 50% chance that it'll be a placebo, because the trial is double masked. The duration of the trial is 2 years, and you might say, why is it so long? These are, Stargardt and other hereditary diseases of the retina are slow chronic conditions, as you know. So it takes some time for us to be able to assess, how the progression is behaving with and without the drug on board. This is not a rapidly evolving condition where you can assess it in weeks or months. Um, and then the primary endpoint for these trials is the a quantitative assessment of the growth of that central lesion in Stargardt, that area of the central retina that is being affected by the disease. And there are a lot of other associated measures there that I'm not going to go into. As far as the inclusion criteria, so Belite Bio has done a very thorough job in making sure that uh, the participants that are enrolled in the trial uh, are carefully selected to give this trial, as good of a chance as possible to achieve its primary endpoints. And so, for that reason, the inclusion criteria have to be uh, carefully curated and sometimes pretty narrow. So for example, the age range for potential participants is from 12 to 20 years inclusive. They obviously have to be diagnosed with Stargardt, and there has to be a genetic confirmation of an ABCA4 mutation being present. Uh, f- uh, we don't have to have two mutations, which, it's a recessive condition, so two mutations are necessary to cause the disease. But with this gene, often one is missed by genetic testing, so one mutation is sufficient to participate in this trial. And then there are certain cutoffs on the area of that central lesion in the retina and how it looks, and I'll show you some general details about it. And then as far as the visual acuity, that needs to be, in order to participate in the trial, that needs to be at the 2400 level or better. So unfortunately, at this point, any lower visual acuity than that would exclude the patient from participating. So for the Dragon study, the first one, um, there was an interim analysis that was conducted um, and at the beginning of the year. And there was a data safety monitoring board, which is a very standard thing for clinical trials. And so the monitoring board, the report was very favorable. They didn't see the need for any modifications to the study. They concluded that Tinlarebant was safe and well tolerated in Stargardt patients. Um, the withdrawal rate from the study, so patients deciding to leave the study, was at 9.6%, um, with the majority of that having to do with personal reasons not associated with the drug. Only 3.8% was due to actual adverse effects of the drug. And that constituted four subjects out of a total of 104. So obviously very, very low numbers of withdrawal, speaking to that kind of well-tolerated profile of the drug. Um, and I'll show you some data on it. The visual acuity was remained stable throughout the duration of the trial. Um, I'll show you a graph on that. Um, and furthermore, encouragingly, the monitoring board recommended that the data be submitted for further regulatory review and drug approval. So this is very encouraging. This is the data that I mentioned. Basically, what I'm showing are graphs that are flat. Uh, on the left is the visual acuity in normal light. On the right is the visual acuity in low light conditions, dim light. And this is pooled data for all participants, those on tinlarebant and those on placebo. And we see that the visual acuity didn't really change throughout this assessment period. Uh, this really speaks to the safety profile. We wouldn't expect the drug to have an improvement of visual acuity, certainly not on this time frame. But if it had some adverse effects on the retina, we might see a drop in the visual acuity, and there was none of that seen. So that's also very encouraging. Um, so I'm sure that you're wondering, so what were these adverse events that led those four patients to leave the study? So here's a breakdown of the all of the adverse events that were reported for this for tinlarebant uh, and their frequency. So we see that about a quarter of participants reported these things called chromatopsia and xanthopsia, basically disrupt kind of abnormalities in color perception. So chromatopsia is when colors seem a little more vivid than they should be, and xanthopsia is kind of a yellow tint to vision. Sort of how Van Gogh paintings are a little bit kind of yellowish. Uh, so that was about a quarter of participants. Another quarter had delayed dark adaptation. So basically, we're talking about coming in from the outside with your normal bright lights into your house, and the lights are off and it's dimmer there, and instead of being able to see pretty much immediately, you have to take a little bit of time to kind of dark adapt. And Another 15 or for 14.4% had a more pronounced version of that was actual night vision impairment. So if you're, let's say, in your house at night and the lights are off, you find it more difficult to see than you typically would. So of note, for all of these categories, the severity of the adverse events was described by the participants as mild. And obviously only four found it to be significant enough to leave the study. And then I also want to mention there was headache reported in 8 patients. Again, mild, so nothing too exciting there. Um, so the conclusion from all of this so far is that tinlarebant continues to be shown to be safe and well tolerated in this Stargardt patient population. The uh, side effects are pretty mild and uh, well tolerated as well. There were no serious side effects associated with the treatment, and certainly no side effects that were systemic. We have to think about that because this is a systemically administered drug. This is not like an intraocular injection. This goes everywhere in the body, and so it's encouraging to see that there were no systemic adverse events. Now, getting into the Dragon 2 study, this is already a phase 2/3 trial. It has a component. Don't be confused. The full name includes a phase 1 component. That's kind of a small add-on to the study. The actual study is a phase 2/3, which is basically the phase 3 is the last phase. So if it shows efficacy and safety by the end of phase 3, then the next step would be hopefully approval. Um, and we've talked about the design, how it's double masked and how it's randomized. Um, and It is currently enrolling. Uh, and I've covered that the primary endpoint is basically the dynamics of that lesion in the central retina and um, you know, measuring whether tinlarebant slows down the growth of that lesion per year. The inclusion criteria, same as I covered, 12 to 20 years inclusive, at least one mutation, documented ABCA4 mutation on genetic testing. There's that range of area size. I don't think those numbers are particularly meaningful to most people, but just to make you aware, if 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 somebody is being evaluated for the study, their retina images are being very carefully scrutinized and quantified and measured to make sure that we fit into that range of lesion sizes. And there is a reading center dedicated to doing that, professionally. This is not a subjective opinion. And again, the best corrected visual acuity of 2400 or better. So just to give you a glimpse into kind of what goes into determining whether somebody can qualify for the study based on their lesion size, this is an example of some patients who are eligible. So you can see that there's quite a bit of kind of calculation that goes into there and marking out what we actually define as the lesion and what we don't, and what the size is by area. And here are some examples of patients who are not eligible. And you can see they do have lesions in their retina, but they're just too mild to qualify for the study. So it's it for some people it may be a little upsetting. They're hoping to get into the trial and um, they go through the screening and they're told, well, your lesion is not big enough. I always remind my patients that, hey, this is really good news. You don't have advanced enough disease that you qualify for the trial. I'm happy about that. Let's hold on to that as long as we can. Um, and thinking about logistics, I mentioned that there are sites in Japan. There are 3 sites in Japan. I think the majority of the audience here is from the UK and the US. So there is one UK site at Moorfields in London, obviously. So that's great that we have that for European participants to come to where they can participate. In the US, there are 10 sites. We are at Duke. We are one of those sites, and these sites are, if you look at them, they're scattered pretty well across the country. So I feel like no matter where you are in the country, you'll find somewhere within relative vicinity of you. So um, hopefully this can accommodate most people who would be interested in participating. We are certainly, I welcome anyone who wants to come get a consultation with us and be evaluated. But all of these centers are of extremely high quality, and um, any of them would be a fantastic choice. So that's basically what I had to share with you today. And we'll see if there are any questions from the audience.
Thank you so much. I'm just going to quickly stop